I know that pharmaceutical companies and medical institutions should be given more incentives to justify their huge R&D investments.
I think that everyone in this room need not be reminded, nor do we need to belabor, that we all advocate here prevention, early detection, early treatment. But we need to ask the questions of, will it really reduce cost burdens? And on whom will it reduce them? How can we shift fundamental financial models? How do we convince our publics, policymakers, regulatory authorities, insurance companies, R&D investment strategies, etc.?
And what we're trying to do is say, if we're going to look at a societal benefit and an economic benefit for beginning to modify the model of very late intervention in disease, we better have an intellectual construct, and we better have some metrics that we can actually measure it. And otherwise, it just becomes platitudes, and that's what we're trying to avoid. So what's the model? What are the metrics? That really has to be one of the key indices. Are you getting good economic benefit for your healthcare dollars? Are you not just getting longer lives, you're getting more productive lives?
For patients, healthcare is about expectations and choices, and incentives play a role in how they manage between those two. The great thing about incentives is that they always work. The bad thing about incentives is they may not work in the way that you want them to. And in the United States, we have a system of very perverse incentives that reward activity and utilization more than they do reward things like health and wellness or being conservative about utilizing care.
There are other demonstration models that I think we need to get to governments around the world with. You must prove to them that early detection and prevention is going to lower their health care spend at the end of the day. That's what you're going to have to do. And I think you can do that by various types of demonstration models. And those demonstration models have to start at the beginning.
From society's point of view, the whole insurance structure we have, we should in fact have insurance executives because we beat them up all the time. They should be hitting back. But a model that we have, what we now worship, is free choice. So every year you can change insurance carrier. And we worship high deductible policies where the first $4,000 to $10,000 are out of pocket. I would say any physician will tell you that is antithetical to early health and these kind of investments. What you really need is life cycle insurance models where somebody stays with an insurance carrier through the life of that person so that it pays the insurance carrier to invest early to save money later.
When you come to the developing countries, it is still a fundamental problem of focusing on prevention and then putting more money into healthcare and weighing prevention against providing curative care. And for political priorities, if you look at them, you find for a politician the time span is always about 2 to 3 years of thinking. And they would always like to invest more in visible things like putting a hospital or providing more number of doctors, etc., or putting more number of medical colleges. But when it comes to prevention, it doesn't figure anywhere in the priorities.
How do we provide decent healthcare or decent health rather than healthcare in a world where maybe it's $35 a year ahead as opposed to $2,000 a year ahead? And I think that's a question which, as we think about early health, we must keep putting that on the table, it seems to me, because that doesn't mean to say it's just a poor copy of the rich man's world. And actually, I think there are some things we can learn as well about thinking about the problem of if you actually had to try and improve health on $35 a year, what would you actually be doing? Wouldn't be using the models that we're talking about now. You'd be going much more where people are. You'd be interesting to hear from anthropologists. You'd be actually using the social systems and so on that are reinforcing health within the system. And it needn't be just a poorer version of the $2,000 model. I think in some ways it may be potentially stuff that we can learn from it.